Hello, I'm Dr. Vasundhara, Senior Consultant Gynecologist, Laparoscopic and Robotic Surgeon, Secunderabad KIMS Hospital. So now we are moving to the second test of these elite questions, and in which the first question is, after menopause, which hormone profile is most accurately described? See, menopause is a state wherein the ovarian failure happens, and the effective hormonal regulation from hypothalamo-pituitary ovarian axis will be disturbed. So, in which the ovaries will be unresponding. So, it is depicted by certain hormonal changes. So, the correct answer would be the low estrogen, high FSH, and undetectable AMH. As I said, menopause is a state of ovarian failure and with decreased estrogen and inhibin secretion. This loss of ovarian function results in loss of the feedback mechanism to the hypothalamo-pituitary ovarian axis, which results in increased FSH and LH hormone. So, in order to stimulate the ovary, so FSH and LH will be raising continuously, along with AMH level, which is being secreted with the granulosa cells, which goes undetected. So, with this background, when we come to the option A, that is the estrogen low, what he has given, high estrogen and low FSH, that is false because FSH will be very high, and the option C is both estrogen, AMH are low. This is even wrong because estrogen and LH is elevated. When we come to the option C, it is given as high estrogen, low LH and normal AMH. No, that is AMH is low. The option D is low FSH, high estradiol and high testosterone. So that is wrong because FSH will be elevated. The second question is, which of the following is an advantage of transdermal estradiol preparation over oral estrogen therapy in postmenopausal women? See, the postmenopausal women, as you know, needs HRT, that is the hormonal replacement therapy, because the ovarian failure happens, and so as the FSH will be elevated with low estrogen supplementation. As you all know, estrogen is the very important organ for the women hormonal function and women systemic functions, and especially the genitourinary organs are all very much dependent on estrogen, for which the postmenopausal therapy has to be given. So in advising HRT also, we have to be very judicious because of the side effects of the estrogen. So all the side effects of estrogen are based on the liver metabolism and systemic metabolism process. So we have to be very precautious while prescribing the estrogen. Among the options, the correct option would be, so we give the transdermal estradiol preparation to avoid the first pass metabolism with little or no impact on thyroid binding globulins and hepatic coagulation proteins at standard doses. Yes, that is the correct option, because as I said, transdermal approach gives the bypass, it bypasses the hepatic circulation. So as the all the circulating estrogen binding estrogen binding receptors like thyroid binding globulins and corticosteroid binding globulins and sex hormone binding globulins are bypassed. So any effect of the estrogen onto the systemic body parts will be avoided. So as the coagulation profile is also not affected, and that is the reason with low thromboembolic phenomena are also noted with hepatic metabolism. So when we come to other options, that is A, significant increase in venous thromboembolism risk. No, it lowers the venous thromboembolism. As I said, the coagulation profile is not affected. Major increase in hepatic protein synthesis and triglyceride levels, no, because as it bypasses the liver is not affected. And D is greater risk of skin irritation compared to oral therapy. It is wrong because it doesn't cause any skin irritation. The third question is, which of the following best describes WHO group 1 anovulation? As you all know, WHO classifies the ovulation into 3 categories based on the hypothalamo-pituitary ovarian axis. The first is hypogonadotropic hypoestrogenic state, wherein hypothalamic pituitary failure happens, in which the gonadotropins are not secreted, so manifested with low estrogen, low FSH, which ultimately results in low estrogen. Group 2 is normogonadotrophic, normoestrogenic. That means the hormonal failure happens with normal FSH levels and normal estrogens. That this happens with dysfunction of the axis, hypothalamo-pituitary ovarian axis. And class 3 is hypogonadotrophic and hypergonadotrophic and hypoestrogenic. That means gonads will be responding more, that the gonadotropic hormones will be more in order to stimulate the gonads. So those are the ovaries. So the failure happens at the level of ovary. So in order to stimulate, the hypothalamus continuously secretes the hormones. So this happens at the level of ovary. So this the correct option for this is C, that is low FSH and low estrogen. So which corresponds to hypogonadotrophic and hypoestrogenic state. And fourth question, which anatomical sites are included in FIGO hypo P classification? See, as we just learnt about WHO and ovulation, that is categorized into 3, and FIGO classification is categorized into hypo P, that is HY stands for hypothalamo, and P stands for pituitary, O stands for ovarian, and other P stands for PCOD. So here it is classified into 4 categories. One is HY, that is hypothalamic dysfunction, and P stands for pituitary, that means pituitary disorders like hyperprolactinemia and pituitary pituitary microadenosis and all those. And ovarian, that is the 3rd category, all the ovarian dysfunctions like premature ovarian failure and all those. Another P stands for PCOS, that is the major most common seen disorder. Question number 5. Which of the following is the main mechanism by which laparoscopic ovarian drilling improves ovulation in men with PCOS? See, for women with PCOS, we usually prefer PCOS drilling, that is laparoscopic ovarian drilling, in which we drill ovary at multiple sites, minimum 4 to 5, in order to express all the cystic fluid out. So what happens in this means the cystic fluid is very androgenic. By letting out this androgenic fluid, the androgenic levels falls down, and the cortical stimulus happens with the thermal ablation, and ovarian functions restores. This is the basic principle behind the laparoscopic ovarian drilling. As I said, because of the cortical stimulus, the androgen hormones like testosterone, all those come down with reversal of the LH ratio, which is the most common factor in PCOS, and with normalization of the FSH and with decreased AMH levels. These are all the changes which happen after laparoscopic ovarian drilling. So when we come to other options, this is the correct option. What he has given is destruction of the androgen that is option A, destruction of the androgen producing ovarian tissue, lowering serum androgens and LH. And yes, that is correct. When we come to option B, removal of the ovarian cyst, restoring ovarian size. It is not the restoration of the size which happens, it is the restoration of the hormonal misbalance. So dysfunction happens. So option C, increasing number of ovarian follicles. This is a typical feature of PCOS, but it is not the clinical part of ovarian drilling. The option D is blocking estrogen receptors in hypothalamus. It doesn't have any relation to the hypothalamus receptors and all those. It reduces the androgenic overload and restores the imbalance which happens because of the PCOS. See, the next question is 6. Analyze this is the picture which is showing a transvaginal image of the uterus, in which here it is showing a well defined round hypoic lesion with posterior acoustic showing with in the myometrium. The most likely diagnosis is, see, this is a typical feature of the fibroid. See, fibroid has typical features in ultrasound. That the typical features here are the transvaginal mode is the best mode in identifying the fibroid, which shows as a well-defined round lesion which is hypoechoic. That means when compared to the adjacent structure, that is the normal uterine structure, that looks a bit hypoechoic and with a typical pattern of posterior acoustic showing. That definitely signifies that as the fibroid. And that should location, It depends on, whether it is myometrium outside the, subserosal or inending onto the endometrium. So when we come to other options like ovarian cyst, no, this ovarian cyst gives a kind of fluid acoustics, and this is a kind of anechoic space, not hypoechoic. Endometrial polyp, this appears as a focal lesion inside the uterine cavity, not within the muscle. Adenomyosis, this is a kind of, which is a very easy diagnosis, wherein the endometrium layer, the ectopic endometrium is layers are seen inside the myometrium, but they do not give a well-defined round hypoechoic lesion, and they show where, they kind of they are not like fibroid, not uniform, and they may show a flakes of blood vessels. Question number 7. So which ultrasound feature under MUSA criteria is considered as an indirect sign and is highly useful, especially when direct signs are uncertain. See, this is uncertain for, this is MUSA stands for morphological uterus sonographic assessment. That means the transvaginal or transabdominal assessment of the uterus in which ultrasound is used. So this is called morphological uterus sonographic assessment criteria, in which it has certain criteria. When we come to the options like echogenic subendometrial buds and subendometrial, no, this is irregular and interrupted junctional zones and myometrial cysts and hyperechoic islands. So the junctional zones is irregular and uninterrupted junctional zones are very much specific signs of adenomyosis. So adenomyosis is a condition wherein we know that ectopic endometrium is seen inside the muscle signs. So which has direct sign and indirect sign with ultrasound. The direct signs are myometrial cysts. That means a kind of liquefaction of the tissue which happens from the endometrial fluid. That means endometrium, which is ectopic endometrium, which is being secreted monthly and gets dissolved on its own. And the lands of hypourea, that indicates that it is liquefaction of the endometriosis, and echogenic subendometriotic buds. So these are all the direct signs. Indirect signs are asymmetrical myometric thickening, fan-shaped shadowing, and translesional vascularity, and irregular interrupted junctional zones. So there are direct and indirect signs, and this irregular junctional zones comes under indirect sign for adenomyosis. What is the maximum score possible in the endometriosis fertility index system? So the maximum endometriosis fertility index system is the score which is usually given after the surgery in assessing the fertility preservation. See, we do endometriosis surgery in order to preserve fertility mainly 90% of the times, or 10% of the times in order to relieve the symptoms. And the score is maximum given as 10. So the correct answer here is B. The score ranges, as I said, score ranges between 0 to 10. The factors here are this endometriotic fertility index score includes histology factors like based on history. Historical factors means based on history like age, duration of the infertility, and prior pregnancy. And surgical factors like what grade of endometriosis, what kind of surgery we have done, and all those, and post surgery recommendations. So the question number 9. A 15-year-old girl, short stature, primary amenorrhea with Turner syndrome, which of the following regarding induction of puberty is most appropriate? Remember, 46XO Turner is a kind of female. Sometimes, many times, that is 46X0, sometimes even 46XY is also seen. So this is a stage where the woman is phenotypically female and with a kind of short stature, and genetic structures are all formed but in a rudimentary stage. So as the main defect is the ovarian function lacking of the ovarian function, which has to be addressed with a hormonal therapy. This hormonal therapy should also has to be started at appropriate time, wherein that mimics the normal hormonal stimulation to a proper girl. So by thinking this in our mind, the therapy should also go in the same way. That means we have to start with the basic course from the age of 10 to 11. After that, and we have to increase the dose gradually in order to stimulate the phenotypic female features to that particular girl, and then in a long term basis, without causing much effects onto the pubic closure of the pubic symphysis and all those, without causing effects onto the systemic body parts. So this criteria, as I already said, so as I said, the puberty induction should be done in Turner syndrome because hormonal deficiency is the key. The therapy should begin from 11 to 12 years, and the therapy has to be escalated very slowly over a period of time, and that should be mimicked with the progesterone in the second half in order to restore, give the withdrawal bleed to the women, and cardiovascular effects should be kept in mind. So with this background, start with high dose estrogen therapy. Option A is wrong because low dose has to be started. Option B, begin with low dose around 11 to 12 and gradually increase. Yes, this is correct. Option C, start cyclic progesterone along with estrogen. No, that shouldn't be started simultaneously. First, we have to give a slow priming estrogen and then to be supplemented with progesterone. D, estrogen therapy should be avoided due to high risk of, yes, that has to be moderated and tailored made, but not to be avoided because these girls do need estrogen. Question number 10, 17-year-old girl, primary amenorrhea, on examination, normal breast, but scanty pubic hair and axillary hair, pelvic ultrasound with absent uterus, as upper vagina and 46XY. These are the typical features of androgen insensitivity syndrome. This androgen insensitivity syndrome, the key features here are 46XY with absent vagina, normal breast development and pubic hair. So this androgen insensitivity is a condition wherein the receptors are deficient. The person is a male genetically, but the genetic hormones will be secreting, but the receptors where they take up these hormones and give the external effects to the body are lacking. So that is the reason these are genetic males with phenotypic female appearance. So as receptors are not functioning, pubic and axillary hair are not seen. So Turner's is a condition 46XO many times and with short stature, and this is wrong. Kallmann syndrome is a kind of the kind wherein no breasts are seen. That is a typical hypogonadotropic hypogonadism. And another thing is Mullerian agenesis. This is absolutely female, a genetic female with developmental defects of the Mullerian ducts, but not genetic defect of 46XY. See, she is 46XX only. So question number 11, which of the following is most characteristic features of classical 21 hydroxylase deficiency type of congenital adrenal hyperplasia in 46XX female? See, congenital adrenal hyperplasia is a condition wherein the classic disorder is 21 hydroxylase, that is a hydroxylase deficiency. Is the one is, this is a condition wherein the 21 CAH is due to 21 hydroxylase deficiency happens in 46XS type. So, which is the most common cause of ambiguous genitalia. What happens in this is the systemic, the pattern of conversion from 17 alpha hydroxyprogesterone to cortisol and then to sex hormones, that metabolism will be disturbed. So what happens is the conversion to this 17 hydroxyprogesterone to 11 deoxycortisol doesn't happen. So the negative feedback mechanism of the cortisol doesn't happen. So it results in negative feedback, and lack of negative feedback results in high ACTH hormones. So as this feedback mechanisms and proper conversion of sex hormones doesn't happen, so it results in ambiguous genitalia. This is also called salt wasting syndrome. With this background, when we come to the first option, increased cortisol production and masculinization of male offspring. This is wrong because cortisol production is decreased, and this is the condition where negative feedback mechanism is not happening. And option B is autosomal dominant inheritance and hypertension. This is autosomal recessive condition. And option C, yes, that is correct, ambiguous genitalia. Option D, high cortisol levels with decreased ACTH production. No, this is wrong because cortisol levels gives, as the cortisol levels will not cause negative feedback mechanism, this ACTH production will be very high. Question number 12. Which of the following laboratory findings is most characteristic feature of primary ovarian failure with 46XX karyotype? Primary ovarian failure is a condition where many times that is genetic or external induced, wherein the ovary fails to respond, and which ultimately results with the hyperstimulation from the pituitary glands. So that by definition, in which ovarian dysfunction happens less than 40 years with low serum estradiol, that means production of the estradiol from the ovary doesn't happen, with elevated FSH level. By definition, these three are the criteria. So based on this, if you take up option A, low serum estradiol and low serum gonadotropin, that is wrong. There will be high FSH. Option B is correct. Option C, elevated serum estradiol, that is wrong because of the ovarian failure, estradiol will be less. Option D, normal serum estradiol, that is also wrong because there is less estrogen and normal serum gonadotropin. This is wrong. There will be less estradiol with high FSH, that means high gonadotropins. Question number 13. Which gene is directly responsible for inducing AMH gene expression in Sertoli cells, leading to regression of the Mullerian ducts in male embryos? So, male embryos are determined by the SRY gene, that means sex determining region and Y chromosome. So, absence of this SRY gene results in development into a female. So, this initiates the expression, SRY gene is the main one which initiates the expression of the SOX9 gene. This ultimately, this mainly acts as a transcriptor which induces the expression of the anti-Mullerian hormone. So, anti-Mullerian hormone is a hormone which is mostly expressed in males, which results in suppression of the Mullerian ducts. So, Mullerian ducts are not developed in males. In female, this Mullerian ducts develops into female reproductive organs like fallopian tubules, uterus, cervix and upper part of the vagina. So, in male, as SOX gene is, SRY gene stimulates SOX9 factor. This ultimately suppresses the Mullerian hormone, which leads to development of the male genetical structures. So, the answer is SOX9. Question number 14. Which of the following is a component of the preoperative ERAS protocol? See, ERAS is the thing which has been implemented in many hospitals for faster recovery, which is ultimately the main goal in surgeries. ERAS means early recovery after surgery. That is the main protocol. It has certain criteria in which if we follow all these criteria, the chances of early discharge and less morbidity and successful outcome of surgery are very high. So that includes carbohydrate loading, in which the ERAS recommends oral carbohydrate loading 2 to 3 hours prior to the surgery with an isotonic complex carbohydrate. That means the hypoglycemic levels and indirect release of the insulin levels are very, very minimized, and post-operative recovery will be very high because in post-operative period patient won't be given much oral diet. So hypoglycemic conditions are not initiated. So this, as I said, this has the benefits of reduced perioperative insulin resistance and lower protein catabolism and better maintenance of the body mass and increased patient recovery with less anxiety, thirst and hunger. So, and clear liquids can be given till 2 to 3 hours prior surgery. This is also very much important. And the fasting recommendations according to American Solid meals are allowed up to 8 hours prior to the surgery, and clear liquids 2 hours prior to the surgery. And prolonged fasting is avoided because of the insulin disturbances. So, and the routine putting of the nasogastric tube should also be avoided. And mechanical bowel preparation should also be avoided unless and until it is a proper, clear indicated bowel surgery. And all these are the ERAS criteria. If you follow these, there is a certain proper table given for this ERAS criteria, in which preoperative, intraoperative, postoperative care is clearly mentioned. So that if you follow all these, and early recovery of the patient happens and can be discharged at the earliest. So 15th question is, in ERAS, perioperative fluid therapy aims at. Yes, this perioperative fluid therapy should be aimed at zero balance, goal directed fluid management. Either fluid shouldn't be overload or less is given. That is a zero balance fluid management, as I said. That is also called evolemia. In a zero balance and evolemia are a kind of similar, in which fluid is neither overloaded or nor less loaded. Large volume fluid replacement should be avoided, because there will be increased length of stay in hospital, which may cause pulmonary edema and complications. Delayed enteral fluids are also not recommended, because at the earliest, early oral therapy is recommended. As I think I have elaborated all the ERAS criteria. Question number 16. For which of the following patients is administration of stress dose steroid is most appropriate in perioperative period? So correct answer is patient receiving oral corticosteroids because of the hypothalamo-pituitary axis insufficiency. Actually, all patients who are on corticosteroids should be given when to and what kind of doses of corticosteroids are to be given at the time of surgery. That is called a stress dose. To be given at the time of surgery is a very important thing. This is called minor, this is based on the conditions wherein minor procedures, moderate procedures, and severe major procedures. And at the same time, patients who are taking a lesser dose and patients who are taking longer dose. If patients are taking 5 mg of prednisolone daily on a long-term basis, then low dose, these low doses usually do not cause HPA axis suppression, and these patients can undergo surgery without an extra dose, because this is a kind in where body gets habituated to this kind of dose, and HPA, hypothalamo-pituitary adrenal axis, is not suppressed. In patients on high dose of corticosteroid prior to surgery, in which HPA axis is disturbed and suppressed, for them, if you put them onto stress conditions like surgery, they need to be given a stress therapy. And it also depends on what kind of surgery they are undergoing. If the patient is undergoing a minor procedure, routine morning dose of this therapy, what they have been using is necessary. If the patient is taking moderate dose, they should be advised to take up their routine dose plus 50 mg hydrocortisone, that is called a stress dose, just before the procedure, plus 25 mg every 8th hourly. And if it is a major surgery, and they should be advised to take the routine dose plus 100 mg. 100 mg hydrocortisone plus 50 mg. That means the dose should be increased. So this is also stress steroid for surgery. Yes, question number 17. On second day of technically difficult abdominal hysterectomy, patient reports numbness over thigh on right side, difficult walking caused by weakness and improper positioning. Self-retaining retractor may have injured the femoral nerve and it passes along the psoas muscle. Which of the following finding is typically associated with femoral nerve injury? Yes. So retractor are the instruments which are used to create more space while doing abdominal surgeries, irrespective of that is more under the pelvic surgeries. So femoral nerve has a nerve root from L2, L3, L4, which is mostly gets affected with these retractors when when they are put more pressure onto the psoas muscle. So this is usually identified by the symptoms, above said symptoms with absent patellar reflex. So then the option A is correct. And inability to flex the knee is kind of S roots, that is not L1. And inability to hip is also wrong. And paresthesias over on the posterior aspect, no, that is paresthesias on anterior aspect. So L2, L3, L4 roots, as I said, those are for femoral nerve. It has got motor and sensory functions and reflex functions. Motor functions are hip flexion and knee extension. And sensory is anterior aspect of the thigh, not the posterior aspect and medial aspect. And reflexes are the patellar reflexes. If you are suspecting any of these conditions, femoral nerve injury can be identified. Question number 18. Which parameter of the PopQ classification represents the apex of vagina? Apex of vagina, scar after hysterectomy. See, the option A, that is point C, is correct. See, PopQ classification needs an elaborate explanation wherein points A, B, C, D, and and other points like GH, PB are all measured, in which the anterior compartment, apical compartment, posterior compartments are measured. The point C depicts either cervix with intact uterus or the vault with the post-hysterectomy status. So the point C level is usually taken for classification of the PopQ. So if this point C, either with the cervix or the vault, is at the level of introitus, that is a condition wherein in normal kind that is up to grade 2. If it crosses beyond that itis, that is classified as grade 3. See, GH is genital hiatus and PB is perineal body. These are not classifications these do not represent the apex of the vagina. Question 19. Bacterial vaginosis is diagnosed with Amsel's criteria, which includes. See, Amsel's criteria is a condition in which it has 4 important parameters, in which clue cells should be seen with mucoid discharge, with pH of greater than 4.5 and WIP test positive. So any of these criteria are seen, then that is classified as bacterial vaginosis. And so when the option, see, the clue cells are the cells which with bacteria, they indirectly give us a clue that the bacterial bacterial infection is there, and they should take up minimum 20% of the squamous cells. And WIF test is a kind of fishy smell on application of the KOH, and pH should be greater than 4.5. And this corresponding to option A, that is 20%. Question number 20. A 45-year-old woman with history of 3 previous sections scheduled for lap hysterectomy to prevent umbilical artery injury and to prevent additions. What is recommended as alternative? See, any laparoscopic surgery, if you are very confident, confident if it is a straight surgery, we go with the umbilical port. If you are suspecting internal additions and complicated entry, then it has to be a palmar space. Palmar space is a place wherein it corresponds with the mid-clavicular line along with the transverse line above the umbilicus. So this is the place where internal organs are not much there and less additions are anticipated, and chances of injury to the internal organs are very less. So this is called the palmar entry. See, this is this has got landmarks like, as I said, 3 cm below to the xiphoid process. Other options like right iliac fossa and all these are wrong because chances of injury to the other structures are very high. Question number 21. A surgeon is performing laparoscopic surgery on a patient with BMI 40. Which of the following should be considered for safe entry? Safe entry should always be, the 100% safe entry is not there in laparoscopy. If you are very confident surgeon, you can go for varus with a thin built women. And if you are anticipating any additions or internal bowel structures injury, go for Palmar's point. If the patient is obese with greater than BMI greater than 30, then you go for open technique. because putting up of varies or Hussons or open 5 mm port, all these will cause you more discomfort because the abdomen wall will be very thick. You will not be able to enter the abdomen even with 5 mm trocar or varies straightly, and that will be misdirected into the abdominal wall or preperitoneal. You will be, sometimes I have seen so many patients in which 5 mm trocar directly goes into the abdomen without piercing the rectum, so the peritoneum. That means you will be misguided, misdirected. Sometimes so many, 3 liters, 4 liters of oxygen will be going, CO2 will be going inside the abdomen wall itself, that is preperitoneal itself, because of the fat which gives us a wrong tracks. So the always when you are anticipating a complex surgery, even a Visiport can misguide you. So then better is to go for open or Hassan's technique. Question number 22. Which of the following instruments is specifically designed for precise dissection and reduced thermal spread during laparoscopic surgeries? See, laparoscopy is a electrothermal mechanism. We use all electrothermal instruments. There are so many ways of using electrothermal source. We use either ultrasonic views, either we go for thermal ablations and all those. Like so many instruments are there, harmonic, thunderbolt, ligature and all those. These have their own mechanism of action. Usually ligatures use thermal coagulation, and harmonic use the ultrasound, and thunderbeat is an instrument which uses both the phenomenon. There are certain so many mechanisms, but every instrument has its own advantages and disadvantages, because ultrasonic wave, it goes with a frequency and it has got a minimum caliber. If you are applying it on the vessels and vascularity more than 5, then the chances of bleeding are very high, but the precision is very high. But for thermal ablations, like ligature and all those, it is based on the thermal energy, but spread to the structures are very high. Every instrument has its own advantages. The options here are harmonic scalpel. Yes, harmonic, and here the confusion would be between ultrasonic scalpel and harmonic. But ultrasonic scalpel also works on the ultrasound principle, but harmonic scalpel is specifically designed with a protection in which further spread is very, very less. Question number 23. Which of the following best describes the capacitive coupling as a source of injury during laparoscopic electrosurgery? Capacitive coupling is a principle wherein transfer of electrical energy happens to other structure with a conduction, with a mechanism called that is conduction, even though the instrument is insulated. That it occurs because of the capacitor is created between two instruments, with the operating instrument and the target instrument. If a conductor is created between these two, then the capacitive coupling happens. So this is the answer for this is B, the transfer of electrical energy from active electrode to adjacent conductive material through a intact insulation. That means we will be thinking or misguided by statement that this instrument is very well insulated and electricity won't be conducted, because no capacitive coupling, when it is there properly not rectified, the adjacent remote organ can be affected. Which of the following statement regarding the thunderbeat surgical device is correct? As I discussed about this instrument prior itself. So thunderbeat is an instrument, as I said, it uses both ultrasonic and thermal bipolar thermal energy in the same, simultaneously. Because it has both the phenomenons, it can be used for vessel ceilings greater than 7 mm, and it doesn't use monopolar energy, it uses bipolar energy. So the option A is wrong, option B is correct. Option C, thunderbeat relies only on ultrasonic, wrong. Thunderbeat is less versatile than ligature. No, it uses both the mechanisms. 30-year-old women, primary infertility, advised non-invasive test to assess tubal pregnancy. The gynecologist chose ultrasound-based technique using EchoVist. Oh, okay. Mixture of air and cell. Which of the following statement regarding this is correct? So for this, option B, that is called hysterosalpingo-contract sonography. Hysterosalpingography or this thing, HECOSY is correct, because here it uses air admixed with fluid. In ultrasound, we will be assessing the passage of the air bubbles through this fluid, air bubbles along with this fluid through the fallopian tubules. We can easily identify the patency. When we come to the first option, it is called fetuloscopy. The fetuloscopy means this is a transvaginal hydrosalpingography procedure with sensitivity is almost 86%. It is called hysterosalpingo, yes, that is correct. It is called falloposcopy to assist. Falloposcopy is a microendoscope wherein we visualize the lumen, not the entire canal of the fallopian tubule. Falloposcopy is a device wherein we enter the fallopian tubule from the fallopian tubule and from the uterine cavity, and we go through the fallopian tubule till the femoral end from vaginal route. Salpingoscopy is a device which we use to assess the femoral end through the laparoscopy. So, the best diagnostic tool here is a sonosalpingography, in which that is saline salpingography specifically, because we will be able to assess the procedure which is non-invasive, that is radiology sonographic assisted procedure. We will be directly seeing the bubbles coming out through the femoral end. That is a simple, non-invasive and non-painful, and not much expertise needed, and this is a daycare procedure. So, I think these are all the basic principles in which laparoscopy and basic hormones of the women, reproductive hormones is covered, basic laparoscopy is covered. These three are and basic instrumentation and thermal sources of the laparoscopy is also covered. Thank you.